Hello and a very warm welcome to this webinar. My name is Dr. Jonathan Sackier and I'll be your chair for the discussion today. In this session, we'll be exploring the challenges that COVID-19 has posed to cancer and chimeric antigen receptor or CAR-T patients. This webinar has been supported by a grant from Novartis and will feature 3 presentations from an esteemed faculty and will then conclude with a hopefully lively question and answer session. We shall begin by hearing from Dr. Amit Patel in the United Kingdom. Amit is the lead clinician for haematology and transplant research at the Christie National Health Service Foundation Trust, and he'll be touching on the management of CAR-T patients during COVID-19 in his presentation. After Dr. Patel speaks, we'll consider the patient perspective, and for this, you'll hear from Natacha Bolanos, the Global Alliances and European Regional Manager for the European Lymphoma Coalition, who'll present her observations and thoughts all the way from Spain. And lastly, we'll round out the presentations with Simona Paratore, who's the head of Medical Cell and Gene Therapy Oncology for the region of Europe for Novartis. Simona will conduct her presentation from Italy, so we're truly international today. Her talk will touch upon the barriers to providing comprehensive patient care during COVID-19 and present the pharmaceutical perspective. Please note the question and answer box off to the side where you're encouraged to enter your questions, which our esteemed faculty will do their very best to answer after the presentations. So without further ado, I pass over to our speakers to begin their presentations. Sit back, relax, and enjoy.
Hi, my name is Amit Patel. I'm a consultant haematologist and intensivist based at the Christie Hospital in Manchester in the UK. I'm the lead for cellular therapies, including CAR T-cell therapies at our centre. I'm going to talk to you today about the management of CAR T-cell patients during the COVID-19 pandemic. My disclosures are shown here. I think it's clear from this slide that there is an increase in CAR T-cell activity across Europe, mirroring the increase globally, particularly in the US and in China. And you can see that most of the increase is due to commercial product activity. You can see the data cutoff here is September 2020. Now, in the UK, March 2020 was when we had a national shutdown. And despite that, you can see that there is very little change in the trajectory of the increase, both for commercial products and most importantly also shown in the light blue at the bottom for clinical trial activity or academic products. So I think that that's quite encouraging that despite the pandemic, we've seen very little change in CAR T-cell activity across Europe. And if we think about how centres, including ours, have adapted to the pandemic, you can see a summary shown here, taken from a position statement actually published quite early in 2020 in the pandemic from the American Society for Transplantation and Cellular Therapy. And it breaks down the CAR T-cell centre resources and potential impact that may have. And I think you can see that for most centre related resources, staffing seem to have the most impact. So for example, slots and staffing for apheresis, for hospital admission, for intensive care admission, for pathology, blood banking, radiology, and so on. And I think that that's important and shouldn't be underestimated. So staff taken out of the system, not just because they've got COVID-19 themselves, but because they've been told to self-isolate because of exposures to other potential COVID-19 contacts. And so staffing is a major risk to a CAR T-cell centre and the ability of the centre to provide care. One of the other risks is in relation to manufacturing capability and shipping and logistics around that, although most of this is taken care of by pharmaceutical companies or perhaps startups with pharmaceutical companies in the clinical trial space. But in truth, actually, this has not been significantly affected, certainly in the UK. And so these resources have been updated recently in the UK by the British Society for Bone Marrow Transplantation and Cellular Therapy, and I've left the reference at the bottom there in case anybody's interested. But if we look at our centre and how we've coped with the pandemic and how we manage our CAR T-cell patients, we see patients prior to being referred or after referred and prior to being seen, whether in the standard of care setting or the clinical trial setting, who have developed COVID-19. And so what we have to do for these patients is we allow them to be deferred for at least 2 weeks or longer until they've had 3 negative PCRs to say that they are clear of infection. And in addition, they would be expected to have had resolution of whichever symptoms they had if they were symptomatic. And we know a third of patients will not be symptomatic. Once the patients have been seen in the clinic, and it's important to say again, they'd be seen alone without a caregiver in person. The caregiver would be typically over the phone or video link. They would then have a number of investigations. And as I alluded to a moment ago, some of these might be delayed because of reduced capacity, perhaps mainly because of staff shortages, rather than because of equipment or other shortages. In the UK, we have a national panel which meets virtually every week, and actually the pandemic's had very little to no impact to that activity. Of course, in terms of trial recruitment, however, some trial activity has certainly slowed down because, again, challenges with staffing and challenges with trial deliverability from activities under the sponsor's remit. But nonetheless, once a patient has been approved for CAR T-cell therapy, or whether in a trial or standard of care, they can then go on to have an apheresis procedure. And of course, the apheresis procedure might be delayed because of capacity at the centre, might be delayed because of challenges in relation to transportation of fresh cells. If one is using, for example, axi-captogene silucil, and recently made available in the UK Tecartus for mantle cell, but also patients who are getting Tisagen Lecucel, where you have the benefit of being able to freeze the cells on site and send those cells at a later time point. There may be challenges with logistics in terms of transportation. In reality, though, we haven't seen that as a major problem. And then when the cells go to the manufacturing facility for expansion and transduction, there may be challenges in terms of staffing at the manufacturing facility, resources in terms of availability of reagents. But again, this has not been a major challenge in our experience. When the cells are returned back to us, again, there's a logistic supply chain issue. There isn't really an issue in relation to availability of lymphodepleting chemotherapy, cyclophosphamide and fludarabine, both of which are fairly readily available in the UK at least. However, after somebody's had apheresis, the patient would then have, particularly in the UK, a 4 to 6 week delay where they may receive bridging therapy. And we've had cases of patients who have developed COVID-19 within this time frame. And what we've had to do is the same as if they've developed infection prior to apheresis. In other words, they would be deferred for at least 2 weeks until they've had 3 COVID negative PCR tests and are free of symptoms. And of course, that does mean that some patients either will not be bridged or will have less bridging, for example, radiotherapy and chemotherapy, than we would want to give. But nonetheless, we try not to delay those patients and take them straight to lymphodepletion. Now, prior to the pandemic, we would deliver lymphodepletion in the ambulatory setting as an outpatient, and then admit the patients for the CAR T-cell infusion for up to 14 days. And after that time, as long as there was sufficient recovery, they could be managed in the ambulatory setting using our nearby housing facility. In order to maintain a COVID-free or COVID-secure environment, what we've done is taken steps to test patients within 72 hours of admission to make sure that they are COVID negative based on PCR. They would then be admitted to have lymphodepletion as an inpatient, followed by the infusion. And then we would generally keep patients for 28 days and not let them ambulate after 2 weeks, because that would then expose those patients to potential infection with COVID-19. In the inpatient setting, all staff are regularly tested, all patients are regularly tested. And so we can be very confident that this is a COVID secure environment. And in fact, we haven't had any cases of infection in relation to this particular time point in a patient's journey after CAR T-cell infusion. After discharge, however, patients will be followed up in clinic. Of course, we'll have disease assessments, CAR T-cell expansion assessments, and B-cell aplasia assessments. And as part of these assessments, we can see that we would expect lymphocyte recovery to occur early, followed by perhaps hemoglobin and platelet recovery. But neutrophil recovery can be delayed and can be very fluctuant. And so this must be monitored very carefully. We typically monitor patients 1 to 2 weekly in our day unit. Hypogammaglobulinemia develops some weeks to months later after the CAR T-cell infusion, but by definition, they have a B-cell aplasia. And so their ability to mount an antibody response to infection is completely diminished. Of course, there will be factors in relation to disease or previous infections or prior therapy that may play into this. CAR T-cell product, for example, captogene would typically be expected to persist for a shorter period of time with a shorter period of B-cell aplasia compared to Tisagen Leqcel. And of course, patients who are not in remission would also be expected to have a worse outcome based on registry data, particularly collected by the American Society for Hematology. But other factors in terms of B-cell recovery and ongoing CAR activity will play into this. So what about patients who have developed infection then after CAR T-cell infusion? Well, actually, in the American registry, you can see that 40% of patients die, 60% of patients remain alive. And that's clearly a much higher proportion of patients than you would expect in the general population, and also higher than you would expect in patients post-allogeneic transplant or autologous stem cell transplant, with the caveat that the numbers are quite small. In terms of how you manage these patients, actually in the UK, the guidance is to manage these patients as you would manage anybody else who doesn't have a blood cancer or has not had CAR T-cell therapy. In other words, patients who have severe COVID infection, i.e. requiring oxygen therapy, would be given dexamethasone. There's patients who have more severe manifestations of COVID-19 may be treated with remdesivir. And recently, based on the data presented from REMAP-CAP, we have availability of tocilizumab if the patient has developed organ support requirements in a critical care area within the last day. And of course, we're very mindful of the fact that patients post-CAR T-cell therapy can have hyperinflammation. That can be cytokine release syndrome due to the CAR T-cells themselves. That can be hyperinflammation due to COVID-19 infection, or that can be secondary HLH, either due to the infection or CAR T-cell therapy, or lack of response to the underlying disease indication or the cancer. In terms of what we would offer now in relation to vaccination, because of course in the UK we've had availability of vaccines since December, and currently we have 3 vaccines available, and they're summarized in this table here. We know that only the Pfizer-BioNTech vaccine had 76 patients who had leukemia or lymphoma. We don't think any of the vaccines had any patients post-CAR T-cell therapy. And we know that these are really only suitable for patients who are adults, either above 18 or 16 for the Pfizer-BioNTech vaccine. And so the recommendations set out by the British Society for Bone Marrow Transplantation and Cellular Therapy, mirrored by those from the EBMT group, are that patients should be vaccinated post-infusion 6 months or so afterwards with any of these vaccines. And that's because we expect B-cell aplasia to persist for at least this time period. If B-cell aplasia has not persisted for that time period and there is some B-cell recovery, then there may be a possibility to treat patients with vaccination earlier than that. At our centre, I have to say, we've been pragmatic because of the vaccination rollout in the UK and the fact that we have no real control over supply and access to vaccinations. We don't want to disadvantage our CAR T-cell patients. So we've advised that they have their vaccine whenever they're called to have it by their GP or their community provider. And that's either in the post-infusion space or in the pre-infusion space, whether that's pre-apheresis or during the bridging phase of therapy. I'm going to stop there and take questions. Thank you very much.
Good afternoon. Hello. My name is Natacha Bolanos. I work for the Lymphoma Coalition. For those who don't know us, Lymphoma Coalition is a global network of 83 patient organizations from 52 countries working in the field of lymphoma. And today I will be sharing with you the impact of the COVID pandemic in the CAR T therapy delivery from the patient perspective. It's well known that the COVID-19 pandemic has impacted virtually every aspect of cancer care and research, from introducing new risks for cancer patients to disrupting the delivery of cancer treatment and the continuity of cancer research. Patients on track to receive CAR T cell therapy typically have run out of time and options. For many of these patients, a delay of a week or more can result in disease that has advanced beyond the ability to be treated successfully. According to the literature available, there have been a huge impact from the pandemic in lymphoma care, and especially in CAR T therapy and bone marrow transplantation as well. Not only from the clinical point of view because of the multiple constraints and the challenge for the healthcare system to deal with the COVID demands at the same time with the treatment of other important diseases, as it is the case in cancer, but also from the patient's point of view, the psychological distress that was added to what is the normal situation for patients. I think it's important to set up the scene. How were the restrictions from the clinical perspective? In the context of CAR T cell therapy, there were disruptions because of the resources, the limited resources to be dedicated to other diseases rather than COVID. But it was not only that, it was the restriction of mobility that had an impact on the patients for traveling to go to the reference centers to receive the therapy, and for the family members and the caregivers that may not be able to travel or were facing restrictive hospital visitors policy, but it was also the staff shortage, the medicines shortage, and the risk of infection and many other things. I want to share with you some findings of the Lymphoma Global Patient Survey. Every 2 years, we run a Global Patient Survey to explore the patient experience on lymphoma care, and we try to understand the challenges and the gaps at global level. This year, we were collecting the answers to this survey from January to March. That means that we were collecting answers at the same time we were facing the first wave of the pandemic. And what we learned from the report, from the findings of the survey, is that patients requiring CAR T cell therapy were at, of course, they were at high risk of infections because they are immunosuppressed. They may require, for this therapy in particular, they may require intensive care units. Is part of the therapy normal follow-up to face to treat the adverse effects of the treatment. And they were concerned about proceeding with care options that may add pressure to the intensive care units that were already busy with the COVID patients. So, but in the context of these patients with such massive burden of the disease who are nearing end of life, not to have access to this therapy could mean that they may have no options afterwards. And it was the same case for the early phase of clinical trials. If we understand what were the limitations directly affecting patients before the pandemic in the normal scenario, there is a huge concern or worries about the expectations. There is a need to manage expectations because patients hope the CAR-T therapy to be curative, and in many cases, that's not the outcome at the end. Or the remission don't last as long as it was expected in the beginning. That's the magic of this therapy. And if we put this together with the pandemic challenges, we understand that patients were hesitant and fearful to proceed with CAR-T therapies in the COVID pandemic environment. They were worried about getting the disease. They were worried about infecting their caregivers or family members. They were worried about the potential exposure associated with the initial consultations, or for them who needed to travel far from their hometown because the treatment center is not in the same city, probably. So at the end, there were a lot of added bullet points to consider that were causing more burden from the emotional point of view. It was not only that, it was the restriction on family visitors and caregivers, the lack of physical presence and support that were placing burden not only in the patients, but why not to mention that also in the healthcare workers that need to be kind of caregivers substitute. It was a thorny situation for patients, and many, when you ask what is your big concern in this pandemic, many answers turn around the worries regarding the impact of delaying the therapy, or getting infected while at the hospital, or the risk of infecting relatives, the potential difficulties in contacting the medical team, also the social distancing, of support for the logistic arrangements that were more difficult during the pandemic because of the mobility restrictions and the lockdown in many areas. It's not only what was happening in the clinical practice, but it was also that the majority of clinical trials, especially in cell therapy, were put on hold, especially those in phase 1. And at the same time, the patients needed to learn how to deal with telemedicine, to remote monitoring, as many doctors were offering this follow-up to provide the best support possible. But of course, many patients, it's not the best setting. They prefer face-to-face medical support because of the challenge for these patients that ran out of options. It's important to consider the social value. With 1, 2, or 6 months of treatment delay, patients with pediatric acute lymphoblastic leukemia lost 9.8 or 36.2 or 67.3 of social value, and patients with diffuse large B-cell lymphoma lost 4.2 or 11.5 or 46% respectively of social value. So it's clear that the magnitude of CAR-T cell therapy value depends on timely patient access, and we need an extremely efficient system to be capable also to educate the patients, to educate the system, for patients also to recognize the symptoms or the CAR-T cell adverse effects in comparison to the symptoms of the COVID pandemic, the COVID disease, and differentiate between them if they experience any of these symptoms. Delaying the cellular therapy as a consequence of the COVID pandemic is not a realistic option at all. a deferral of CAR T-cell therapy, although with temporary intent, that it's longer than expected at the beginning, could prove to be permanent, and those eliminate an otherwise potentially curative therapy. So for the patients who are in need, delaying CAR T-cell therapy would be detrimental unless justified, and the only way to justify is a confirmed COVID-19 infection, for instance, or super high risk of toxicity or poor outcome, because at the end, it's about getting the best for the patients.
Good morning, everyone, and thanks for the invitation. I'm Simona Paratore. I'm the head of medical for cell and gene therapies at European level in Novartis Oncology. And I'm here today to share with you our experience in ensuring CAR treatment during COVID. I forgot to mention you that I'm an MD as a background. I'm Italian, and I live in Milano. To go back on what happened last year, on the 7th of March, Lombardia was considered a red zone. And on the 9th of March, Italy was the first country in Europe entering into a lockdown, as only on the 12th of March, WHO announced the COVID-19 pandemic. We know that CAR T is an individualized therapy, and every product is manufactured for each individual patient and can be used only for that patient. I will not enter into all the steps of the manufacturing process, but what I want to highlight you is that everything starts from the patient's cells. They are collected at the hospital level, they are shipped to the manufacturing site, and then when the final product is ready, it is delivered to the hospital for the infusion. COVID-19 put at risk CAR therapy for several reasons. First of all, the impact on the patient travel due to the stringent measures put in place in the different countries, but also due to the fear of the patient to travel and to go to the hospital. And I know very well what it means, as my father, during the first wave of COVID in Lombardia, was diagnosed by melanoma. And he was so scared to go to the hospital that it took me a lot to convince him that cancer would not wait. Another risk is related to the transport disruption. And we just highlight the importance to have a timely pickup of the cells to start the manufacturing, as well as a proper delivery of the cells for the infusion. And there is a risk also related to the manufacturers, as the people who are working there are at least at risk of infection, as well as the other people. In order to ensure a successful manufacture and the therapy for every patient, we focus on three main pillars: the supply chain and the CAR manufacturing, as well as the CAR management. And I have to say that it was not an easy journey, but the team and the system put in place from the beginning any kind of measure to ensure limited or no disruption. And to give you an example on the supply chain, you remember that I just showed you that on the 9th of March, Italy entering into a lockdown. But we had at the same time patients waiting for the pickup of their cells or waiting the final product for the infusion. And the flights were canceled at that time. So Novartis decided to organize ground transportation to solve the issue. That means that we had car crossing the Alps or driving for more than 700 kilometers to ensure a timely pickup of the cells or the delivery of the final product. On the second pillar, on the CAR T manufacturing, I'm proud to say that all the facilities remain open. We put in place several measures to ensure the safety of the product as well as the safety of the employees. And what was crucial was the possibility to leverage a global network of manufacturing facilities around the globe. On the last pillar, the CAR treatment, we monitor since the beginning the availability of tocilizumab. As you know, tocilizumab is used for the management of adverse events related to CAR-T, but especially at the beginning, there was a concern of a possible stock out of the drug due to the use in COVID patients. So we prepare several backup plans that we didn't use, lucky us, as no needed. But we were closely monitoring the situation. On the other side, we continue the onboarding and the qualification of CAR treatment center in Europe in order to ensure an easier access to the treatment for the patient, so closely to their house. And we also leverage all the communication channels available to ensure to stay connected and close to the scientific community to share our learnings as well as to find solutions together when needed. And this is what happened also last Christmas when the mutation of COVID was identified in UK at the same time of the Brexit. And we had there a patient waiting for the product. But due to the flight restriction and the border closing, the situation was not easy. And unfortunately, neither the ground road was available. And we didn't have neither clear guidelines on the import and export documentation due to the Brexit. But despite everything, we found an ad hoc solution in order to ensure the patient treatment. So the key learnings based on what we did and what we are doing every day is the resilience of the system. And it's also how important it is to find and to be open to innovative solutions to overcome the challenges and to work together in a close partnership, everyone with his role, in order to achieve our common goal, that is not to leave any patient behind. And with that, I want to thank you.
Okay, thank you very much, Simona. And in fact, all of our awesome faculty for 3 equally important presentations, different content, stylistically different, but all great. I've got plenty of my own questions, reminding you to post. I think it's in that direction. Look for the question mark. Stick your questions up there. We've already got a few. I've got plenty of my own. And I'm going to turn to the faculty and sort of bounce around between them. Amit is based up in the Manchester area and tells me he likes to go for walks. Seeing as we're in the middle of a blizzard at the moment, I don't know that he's getting much exercise. And Natacha has hiding behind her deaf and slightly psychotic cat. Appropriately, there he is, appropriately named Handle. So don't get frightened if he suddenly leaps in. And Simona tells us that she's been battling her way through lockdown, becoming a master baker. So I'm looking for a delivery of croissant very soon. So I'd like to start with a question that's appeared several times already in the panel, and that's about clinical trials, excuse me, during this pandemic. And I think I'd like to start with you, Simona, if you can give us your perspective. What's happened to CAR clinical trials?
As of now, CAR trials are continuing, but it's fair to say that what happened during the first wave, that both the health authorities like HEMA and the FDA released recommendation in order to ensure a proper management of clinical trial, especially to ensure the patient safety. And they suggested to evaluate carefully the risk-benefit, but they were also highlighting how important it was to take into consideration the burden in terms of time and staffing during the pandemic as well. So from our experience, we mitigate the situation quite rapidly, and we leverage the remote monitoring, for example, and we put in place any innovative solution to be sure that the trial continued. We had a pause for a few weeks, so that's fair, not in all the trials, but in some of them. but we were able to start immediately after, and now are ongoing. So that's what happened. Yeah.
It's encouraging to hear. Amit, do you have some perspectives to offer?
I would agree with that. I think that there certainly was some disruption to clinical trial activity for all the reasons outlined. I think at trial centres, part of the issues were around staffing, really, related to trial setup, trial management, being able to accommodate on-site monitors, which is why remote monitoring was then pursued and accepted, really for the first time, in the clinical trial space. And then in terms of being able to have capacity to offer follow-up at the time scheduled points in the protocol, really again related to staffing capacity and people being sort of redirected to deliver COVID-related care. So I think there certainly was some disruption, particularly for early phase studies. For later phase studies, there was less disruption, I think, because the justification of a potentially beneficial therapy to patients was stronger than in early phase studies, where really we're looking at an experimental therapy where the proof of concept may not have been established.
Great. Yes, please, leap in.
Yes, if you allow me, I would like to add something, because it's not only what is happening on the side of the clinical trial, it's also what's going on the side of the patient. And for the patient, there are many challenges, that suddenly appear on a scene and they haven't considered yet. And clinical trials are the only option to access to CAR T for many patients, because so far the criteria to access to CAR T, is restricted to some characteristics and some lymphoma subtypes and leukemias, but there are many other options on clinical trials. So I very much appreciate, and I want to highlight, to remark the efforts that regulatory bodies and the pharmaceutical companies and researchers, clinicians have done to ensure continuity of trials. And we should learn from that for the future, for the near future, to make, to put on the top of the needs for the patients, to have more trials in more countries and targeting more disease areas.
So let's stay on the topic of education and stay with you, if we may, Natacha. How can healthcare practitioners optimize the level of information for patients, and frankly, not only patients and caregivers, but also primary care physicians for whom this may be new and interesting? And then after you, Simona and Amit, I'd like to bring you in and get your responses to that.
Yes, thanks for the question, because the data we have captured in the Global Patient Survey in Lymphoma Coalition prove that patients do want to receive more information, and more transparent information in the sense of realistic, to set up the realistic expectations. A lot of patients consider CAR T as the only curative option for them, or the last option, and this put a lot of anxiety, and they don't always receive as much information as needed regarding every little step of the treatment, from the start to the end, how it's going to be their life impacted regarding, not only the adverse effects that we talk about in the clinical outcomes, but the patient outcomes, all the things that may modify your life. And there are some patients that do not do well with the therapy, or not as well as expected from the beginning. It's important to, align expectations with the reality, and also to inform patients about symptom management, but also on what other options they may have in case this doesn't work, as expected. It's important to involve caregivers from the point of view of how we can help to build those discussions among healthcare professionals and patients. On Lymphoma Coalition, we have published a toolkit that has a number of questions that we recommend patients to bring to their doctors, to their nurses, and to the clinical team in general, to guide, and not to miss any important piece of information. It's important to be active from the healthcare professional perspective. I mean, to bring questions and to ensure that the patients are understanding of the information is well captured and well retained in their minds or in the mind of family members or caregivers.
Simona, do you have anything to add to that?
Yeah, that is crucial as well for us to ensure a proper education. We are trying to support any initiative that can help on that. We did also during the first wave. I remember that we tried to support any initiative to share everything that was known at that time, just to be sure that information were available for everyone. So it's something that we are continuously doing with the scientific community. And we want to try to cover as much as possible all the gaps that are still there.
So, I mean, I want to change tack a little bit and ask you about timing of CAR-T. Should it be considered at earlier times of therapy, or is even a first-line therapy? Under what circumstances?
Thank you. So I think that this is the tantalizing question that patients and healthcare providers really want the answer to. At the moment, we've got labels for using CAR T cell therapy typically in the third line space for lymphoma and leukemia, and for leukemia in patients with primary refractory disease. So essentially, as has already been described, this is a desperate situation where somebody has got completely uncontrolled disease, doesn't really have any other viable treatment options that have a curative potential to provide. And I think the place of CAR T cell therapy has been well cemented for that part in the patient's treatment pathway. But there are studies, for example, the Belinda study, the Zuma-7 study, which are investigating for large cell lymphoma CAR T cell therapy in the second line space. And recently, data presented at the American Society for Hematology in December, using data from Zuma-12 for CAR T cell therapy in the first line space for large cell lymphoma. So it is coming. It does appear to be effective in the data that have been released. And certainly, I think, going forward, that is going to be a viable option. In ALL, a study called the Sackier study is investigating CAR T cell therapy in earlier lines of therapy. So I think that the work is ongoing, and hopefully we'll have a readout soon to then determine whether this is helpful for patients. And I think, if the data is as the abstracts have been, I think this will be here to stay.
Simona, do you have anything to add?
Just to highlight that it's our commitment to support clinical trials that are ongoing, as Professor Patel just mentioned, that we'll investigate it. So it's not yet a reality. We all hope that it will be in the future for the patient.
Absolutely, and thank you for that support. Natacha, you were talking about communication with patients, with caregivers, with primary care doctors. Inevitably, at some point, we're going to be talking about palliative care for patients, the role of CAR-T there, and again, harking back to your comments about communication. Do you want to take that first?
This topic was well addressed yesterday. During the CAR-T European meeting, and I want to remark how important it is to consider palliative care and symptom management in general for CAR-T patients. It's not always talked. We don't always talk about this topic, but it's important to see not only the side of helping patients to have a better well-being and transition, through the therapy, but even for those few patients who at the end, sooner or later, will face the end of life. I mean, it's important to take their hand and to go with them, ensuring the best quality of life possible. And preparing your mind and preparing the clinical team and preparing the family, it's an important thing we all should address.
So I want to ask you, Simona, and I want to put a personal perspective on this. I don't think there's anyone, any of us and anyone watching this who hasn't had a loved one, a family member deal with cancer of one form or another. And I want to congratulate you and the incredible work your organization does. You shared the story about your father having melanoma, and I hope he's okay. In addition to what your organization had to do to manage supply chain issues, did the volume of questions, concerns from patients and their families increase at what has been a wretched time for all of us, even those of us who are not dealing with, those people who are not dealing with chronic disease?
So there are different, of course, requests and needs. So we are trying to support as much as we can any tools, any innovative approach that can help in really figure it out what could be the best solution for that. But what was the learning for all of us that we need to be really open to new solutions, but also work closely all together, because in a crisis it's crucial to work as a team, to really define what's the best option and to be brave enough to challenge sometimes the status quo, but yeah, for the final benefit of the patient.
Okay, so Amit, there's a question here. Has the pandemic strengthened the case for off-the-shelf allogenic CAR T products compared to currently commercially available autologous CAR T products? You want to take the first crack at that?
Thank you. No, I think in theory, I think that's true. So allogeneic products have the benefit of being available immediately at the time of need. So there isn't this bridging phase of treatment of 4 to 6 weeks in the UK in order to wait and hold a patient disease who has, by definition, got relapsed refractory disease to available therapies prior to CAR T infusion. So I think absolutely, theoretically, that seems excellent. In reality, we don't really have much traction in this area other than the proof of concept space. So the proof of concept of allogeneic CAR T or CAR NK or even CAR NK T cell products has been made and is being made. Whether that really translates into a viable therapy that's an alternative to autologous, which is personalized, CAR T cell therapy remains to be seen. I think there are some groups of patients that might benefit. For example, patients who have rapidly progressive disease who are unable really to wait 4 to 6 weeks and have their disease controlled for 4 to 6 weeks. Those patients, I think, will definitely benefit from this approach. But patients who have more stable disease may see, for example, higher levels of CAR T cell expansion, cancer activity, and perhaps persistence using autologous cells that are engineered versus allogeneic cells, where in general, and it's, I think it's difficult to completely generalize, but in general, the persistence tends to be lower in terms of autologous products. So I think, there's a lot of work to do. One final point to make is in the autologous space, we have this 4 to 6 week gap. There are emerging data of manufacturing processes where, for example, you're able to make an autologous CAR product in 1 day. And data have recently been presented again at the American Society for Hematology meeting in December, and the recent meeting mentioned by the European Hematology Association in EBMT a few days ago. So I think that there is a lot of development which may make allogeneic products perhaps less attractive in the future.
So watch this space is going to be key. I'm keeping a very close eye on the ticking time clock and on the questions as they're popping up. I'm going to come back and we're going to have a robust discussion about vaccination. And I'm also giving you 3 delightful folk the heads up that just before we close out, I'm going to ask you for 1 sentence each on something really, really pithy that's a take-home message for anyone who's watching. Natacha, I'd like to come to you now. Your slides included two very powerful statements that I wrote down. You delay, but time will not. And do it now, which sounds like an advertising slogan for a well-known brand of athletic shoe. Do it now, sometimes later becomes never. Very impressive. What were you most commonly hearing from patients at, again, what has been a very difficult time?
Wow. Well, it's important not to delay treatment, but it's even more important not to delay discussions about the option of having this treatment with patients. I very much appreciate when we talk about moving CAR-T, to earlier stages, because with the current label, we have CAR-T at the very end when cells are exhausted, patients are severely retreated and accumulating also late effects and adverse effects, but they don't always have access even to discuss about these options early on the patient journey. So again, we should be offering this option to each patient in need of this, and that means that we need to do bigger efforts to bring CAR therapy to those countries where it's not yet available, or to facilitate logistics. And that means that for the patient, sometimes is very, they do not have the financial option by themselves to cover transportation, accommodation, and they need a lot of support from the psychological point of view as well, to address.
Especially at this time, and I want to get a quick response from the others. At this time, people are frightened of traveling. They're frightened of being in a hospital environment, healthcare environment because of COVID. Yes. Are you seeing a drop in referrals? And, how big of a problem? Amit, do you want to tackle that?
Yeah, so we have not seen a significant impact in referrals for CAR-T therapy. And, I would sort of make sure patients understand that CAR-T therapy, at least in the UK, and our centre is a good example of this, is relatively undisrupted, and access is available at the time of patient need. So I think it is important to remember that the hospitals are COVID-free environments, and so it is important not to worry about coming for therapy. And in the relapsed refractory leukemia lymphoma space, unfortunately, the sad reality is that the risk of not surviving because of uncontrolled disease is almost inevitable. And that can be circumvented with CAR-T therapy, whereas the risk of getting infection and not surviving from infection are both not inevitable.
Yeah, we're seeing it across multiple diseases at the moment. People with heart, myocardial infarctions not going to hospital. It's a complex question. I mean, staying with you, and I want to talk about vaccination. I'm going to try and congeal a few questions. So vaccination recommendations you addressed in the United Kingdom, might there be a rationale for a mixed vaccine protocol for CAR-T patients? I know there are trials underway looking at that. And what about intervals between doses? So the approval trials had a 21-day gap, yet the UK is going way further than that. And is it different for CAR-T patients? And what of COVID-19 vaccination in CAR-T patients with B-cell aplasia? And if you can remember all of that, you're even more of a superstar than I already think.
Wow. Okay. I shall try and address that. So I think in CAR-T patients, the target is CD19, which is the cell surface marker on B cells. So if the CAR-T cell therapy has worked, the B cells should be completely absent. And we see that when we look at B cells in the peripheral blood. So theoretically, you would expect to not be able to mount an antibody response to vaccination. What we've seen, though, in some data from the US is that for reasons that are not entirely clear, patients post CAR T cell therapy with ongoing B cell aplasia are able to mount a response. The antibody response is blunted, but still there is some. And that may be because there may be B cells in other compartments that are not sampled outside of the blood compartment. The second is that these patients can also mount a T cell response, and it tells you how important the T cell or the non-antibody response is in conjunction with the antibody response post-vaccination. So as I said, our policy is to just get vaccine into patients whenever it's available, rather than necessarily wait for 3 to 6 months when some patients may have may have B cell recovery, and therefore theoretically may be able to mount a better antibody response. But actually, because there is a T cell response that's mounted, you'll get protection into your patient by vaccinating them as soon as you can. In terms of timing, so the gap between the first and second dose, it's clear from other vaccines, so not just COVID vaccines, that a longer gap usually gives you a more mature and better, longer lasting and immunity against whatever it is you're vaccinating. So the same should be true for COVID-19. And I think in the last day or so, Professor Sarah Gilbert from the Oxford group has published some data that speaks to that. So in other words, for their vaccine, a longer gap, a longer interval seems to give a better anti-COVID-19 response. In terms of the question of mixing the different vaccine types for example, dose 1 or dose 2 or 3, if we're going to get subsequent doses, which seems likely, again, theoretically, outside of the COVID-19 setting, that does confer benefit, even if the target is the same. For example, the spike protein, if the mode of vaccination is different, then that does seem to be beneficial. And again, that is being addressed in a number of clinical trials that are ongoing for COVID-19 vaccines. So I think we will have a readout soon in relation to that.
Well, my guess is we're going to have you guys back because there's so much to talk about. I'm conscious of time. I did give you guys a heads up that I wanted one sentence from you. So you've been talking. I'm going to let you go last. We'll start, Natacha. What's your one big takeaway?
Do not delay treatment, but do not delay patient information, patient education, and patient support.
I love that. Simona?
We show the resilience of the system. We manage the CAR-T manufacturing. We are managing. So that's now done.
And Amit?
I would say don't delay, come today. CAR-T therapy awaits.
Yeah, you just need to make it rhyme, and then you've got a marketing thing. What I love about this conversation is we have different perspectives presented by people who are all focused on the same thing, and I'll close with that. That's all we have time for. I want to thank our amazing panel, Amit Patel, Natacha Bolanos, and Simona Paratore. I also want to thank, again, Novartis for providing the grant that made this possible. The technical assistance provided by Michaela Byrne and Mariana Napoleo and their colleagues, and of course you, our audience. Thank you for dedicating your time to help improve patient care. They're very grateful, and bear in mind, we'll all be patients sooner or later. So it's goodbye from me, Dr. Jonathan Sackier. Stay safe, stay well, and stay well informed.